So I just said lymphoscintigraphy is often known as being painful, but ICG injections are not. And we actually use a CoolSense device that we numb the skin before giving the injection. And so it's not at all painful.
The next question we have is kind of a secondary question to this. Were the drainage patterns consistent for the patients with upper extremity lymphedema, regardless of node dissection and/or radiation treatment? I think you talked about different patterns of drainage.
Yeah, so the drainage regions that we reported out of that 416 individuals, 90% of them had had an axillary dissection. I'm not sure off the top of my head how many had the radiation, but we do have all of that data. And they were the 5 most common drainage regions.
And then this question, I think we could go to either one. I think primarily, as you were speaking, the question was coming in, Cheryl. For patients receiving neoadjuvant chemotherapy, do baseline measurements need to be obtained prior to chemotherapy because of the potential edema related to chemo?
We do try to get the baseline measurement pre-neoadjuvant chemotherapy, but in our data, as I had mentioned, we have not found that the neoadjuvant or taxane-based chemotherapy has been a risk factor for lymphedema. I would argue if you don't get the baseline pre-neoadjuvant, at least get it pre-surgery. It's not always possible based on the appointment scheduling, so just as long as it's pre-surgery.
And another question for you. Do you consider a patient having sentinel node biopsy only at risk for lymphedema and part of the surveillance? And I think you answered it maybe as a question was coming in, but maybe you can give us a summary.
So yes, those who undergo sentinel node biopsy only, so no regional nodal radiation, have about an 8% risk of lymphedema at 5 years. So again, they're at very low risk, but they are not at 0 risk. So I think best practice for them is to give them prospective surveillance of some kind. Maybe it's at a lower frequency as the alert group recommended, but still to have some longitudinal surveillance is best practice.
I totally agree with what you're saying there, Cheryl. And my dear Professor John Boyages, who I still work closely with, he said to me, Louise, unless you can tell someone that they have absolutely 0 risk of lymphedema, you need to give some form of education and of screening. And I think that's good that, you know, we've got to give them some monitoring. And I think these patients in particular, we probably see more breast edema from those who might have lower axillary surgery but have the sentinel node, and there's a lot more work happening in the breast edema side. So if they're part of a screening program, we're also asking them questions about their breast as well.
Anybody in the room with any questions? Oh, there's a microphone right up here.
This question is for Cheryl. I'm just wondering, the pre-surgical asymmetry measurements that you had taken, were they based on perimetry or were they based on BIS?
They were based on perimetry. So it would be a volume difference of a percentage difference. If it were based on BIS, then we would be looking at the LDEX score. Yeah.
And just a different question too. The weight loss was found to not be protective of developing lymphedema. Is there any study of prevention of progression with weight loss? Is there any protective from the progression of lymphedema versus just the acquiring the lymphedema?
Not that I know of. So weight fluctuations, yes. So sorry, the comment was if you gain weight, that will increase your risk of lymphedema. So weight fluctuations, yes.
Education that has changed over the years too, because there's a study that came out. Don't worry about flying. Don't worry about blood pressure cuffs. So what is education?
That is a great question. I'm going to turn this over to Cheryl.
So that's our paper that you quoted, and we did not say, don't worry about it. And that paper was misconstrued. We never said, don't worry about it. What we said, and our conclusion very clearly, is isolated blood pressures, isolated venipuncture are not associated with increased arm volume. We didn't say go willy-nilly and have, 50 blood pressures and 50 venipunctures and do whatever you want in that arm. We undertook that study because many of our patients have bilateral lymph node removal and are at bilateral risk. And what do? Right? They have to make a decision about medical procedures. And in some patients, the non-at-risk arm has been punctured so many times, they have no more venous access left. So at MGH, if we need to use the arm at risk, we will. And we've found that not to be an issue. And in fact, I'm just writing a manuscript now on infusions and lymphedema, and we've found the same thing. Most of the patients who had infusions in the at-risk arm had 1 or 2 infusions, and it was typically their last chemo or their second last chemo. They didn't want to have a port put in, so we went to the at-risk arm. They went to the at-risk arm and did the infusion in the at-risk arm with no increase in arm volume. So we're finding the same thing. So many patients prefer to have medical procedures in the unaffected side and avoid using the affected side, and that's absolutely fine. But our purpose to doing that work was to address patients who have risk both sides, or who have an isolated procedure. Maybe their patients have said, I was looking away and suddenly the needle was in my arm, and they're very fearful. So to be able to say to them that we have found that isolated venipunctures were not an issue on that side. I will also say we didn't study automatic cycling cuffs, and we need to be particular about that, like in the OR.
Thank you. One more question online. I'm going to read it. I have found that deeper pressure MLD is indicated in patients who haven't eliminated food allergies, but lighter pressure works best in patients with food allergies eliminated. Do you know of any research in this area, or have you considered this in your practice?
No, we haven't. We haven't done any research in this area. And I guess what we have found is that the lighter pressure, we're not seeing any movement of the lymphatics when somebody's got congestion or dermal backflow in that area.
And you have access to the ICG, so you can using that as a guide of how much pressure to use. We have another question. Do you have a good way to measure breast lymphedema? You can both answer that one.
Spend a day on that one after the 6:30 meetings over the last few months. So we are looking to study that in particular because it would be really nice to have a bedside ambulatory tool to measure breast lymphedema. There have been a few studies looking at high frequency ultrasound to measure breast lymphedema, and also looking at tissue dielectric constant to measure lymphedema. And now that Dr. Swami and the ALERT group has done so much good work on ICG drainage of the breast, we really have, I want to say, a gold standard or a true direct lymphatic function measure with which we can validate those measurements. So I think we'll be looking at trying to validate tissue dielectric constant and ultrasound as measurements. Until then, we are left to measure radiation tattoos and freckles and mid-axillary to mid-sternal line, for instance. But I've been using tissue dielectric constant in practice to measure for breast lymphedema.
Same. Okay. Any other questions in the room? We also have a microphone at the back.
Based on the data you have from risk analysis, are you having everyone wear a sleeve post-surgically to minimize risk, or is it based on meeting a certain risk percentage before you choose that?
Thank you for that. that study that came out was, it's quite a different population than we have. It was all patients who underwent node dissection. So we are not putting that into practice just yet. In our ideal world, we'd love to study that here. So we are not putting everyone post-surgery into a sleeve at this point.
Yeah, and we're not routinely either, but we have got Vincent, who has joined our team, who is the senior author on that paper. That study was a randomized controlled trial done in India. He's an Indian background, and it was done during COVID time. So one of the limitations is that we're interested to do further study in it is looking at the compliance and adherence to wearing garments, you know, putting them on when they've just been going through their breast cancer surgery and treatment. But it's something, yes, where there's a lot of momentum in Australia and here, I think, to be really looking at that, because if it can make a difference to prevent, then I think we should be exploring it more.
And I'll say at the Boston Lymphatic Center, we have an additional benefit of a workup, preoperative workup for every patient who's undergoing axillary lymph node dissection. We also offer a preventative lymphovenous bypass at the time of the axillary dissection. You'll hear more about this tomorrow when Dr. Singal presents on lymphatic surgery. So part of the workup involves a preoperative ICG. And actually, we have found in isolated patients some positive ICG findings prior to having the axillary lymph node dissection showing dermal backflow. And for those patients, we do put them into a postoperative sleeve, and we're tracking those patients. It's not a large cohort, but that's kind of what we're doing as a practice based on the ICG findings. Any other questions? I'm going to have you just put it, speak in the microphone, so for the benefit of the people at home.
Just related to treatment, I've been hearing in recent years of therapists using vibration plates, dry brushing, some sort of wooden paddle with an Asian name that I don't remember. Have you come across this, and is there any evidence-based research on the effectiveness of this? No, didn't think so, but I had to ask.
And I'm just going to give you the microphone so the people at home who can't see you can.
No, we're not doing any research, or I haven't heard of those things that you've mentioned, actually. So we're really focusing on good CDT treatment. There's other additional treatments which we haven't really mentioned, but I'm sure will come up in the next 2 days. There's things like pneumatic compression pumps, laser therapy, kinesiotaping, things like that. And I think there's also new additions in 2-layer bandaging system that may be beneficial for our early intervention patients who might not have the really big limb size volumes and, you know, lobules and things like that, that might, you know, benefit from the multi-layer. But we are doing a lot of 2-layer bandaging in Australia with our early intervention patients who we just need to get them down a little bit to get them into a good fitting garment. So, you know, there are advances and innovations, but not in those things you've mentioned.
And then tomorrow we'll also be hearing from Leslie Bell, who will discuss compression strategies, but also has she also talks about other adjunctive treatments. She has a huge toolbox that she'll share with us and some very innovative ideas. Please go ahead.
One practical question about the 3D camera. Is that an app, or is that an actual physical camera you have to buy that's separate? Does anyone know anything about that?
That is an actual device. It's called Lymphatech. It's developed by 2 engineers out of Georgia, and it is a 3D camera attached to an iPad mini, and they have copyrighted trademarked software that is used to calculate the volume of the limb. So it's called Lymphatech. If you wanted to reach out to the company, they'd be happy to tell you more.